Well, thanks everybody for joining. We're going to go ahead and jump in. I'm Sean Pinegar. I'll be your host today. Like many of you, I am a heart patient. I inherited a genetic variant, if you will, that led to bouts of VTAC, ultimately an ICD, and then a heart transplant. And as many of you know, living with a heart condition can feel overwhelming. It's not really just the physical symptoms, but the uncertainty, the worry about the future, and the impact on your family. Many patients say that the emotional toll can be just as heavy as the medical one. And that's why today's conversation is so important. And we're here to talk openly about these challenges and to share tools and perspectives that can help you feel less alone and more equipped to live fully with your condition. Before I bring in our guest here or introduce our guest, I want to quickly thank our sponsors, LMNA Cardiac and DCM Foundation. Without them, this type of conversation wouldn't be possible. They're doing tremendous work in supporting patients and advancing care that makes this conversation possible today. Today, we have the privilege of welcoming Dr. Samuel Sears, professor in the departments of psychology and cardiovascular sciences at East Carolina University, where he also serves as the director of cardiac psychology and associate program director of the Cardiovascular Disease Fellowship. He's internationally recognized as the leading authority in cardiac psychology, publishing over 200 peer-reviewed articles with more than 13,000 citations, shaping how both the medical and psychological communities understand the challenges of living with heart disease. His work's had a profound impact, and Dr. Sears, it's really an honor to have you with us today. I'll turn it over to you so you can share more about your work and your perspective.
Well, Sean, thanks for that great introduction. I appreciate that. I've had the privilege of working with heart patients for the last 30 years in clinical practice. And what's been most distinguishing is that we've embedded ourselves in cardiology, that the the physical presence of a psychologist in a cardiac clinic means that all patients who have a heart problem also have a impact on their mind. It doesn't necessarily mean they have a mind problem, but it does mean that their mind is affected by the conditions. Finding peace of mind, finding tolerance for the unknowns, trying to remain optimistic about the future. These are simple words in challenging situations. So, just to give you a little bit of background of what I do. So, my research is been focused on the psychological aspects of a host of heart diseases. The ICD has been the focus because when I was a young psychologist 30 years ago, I met with heart transplant patients or patients being considered for heart transplant, and along came this very primitive ICD that produced a lot of ICD shocks because it was very primitive, unprogrammable, in fact. And I said, gosh, this is really something we better understand soon because these patients are really suffering. And we just set out to study those patients and to take care of those patients and do everything we can to advocate for how we accommodate this incredible technology so that patients could live with it. And that's what we've done. Our most recent work's been focused on using the accelerometer inside the device. So, the ground to gravity movement between when somebody walks, just like the step counter, and understanding how could we use activity information as a proxy, as a marker for mental and physical health. And so we've been very focused on that. In addition, we've focused more recently on very specific kinds of anxieties for ICD patients and patients with vascular disease like aortic disease, where what are the specific concerns? Not just I'm scared, I'm anxious, but what specifically are their fears about? Fears like, of course, ICD shock, fears of exercise, fears of triggering an arrhythmia, and the mind games that can go along with all that. So what we've tried to do is really become, I don't know, maybe walk in our patient's shoes as close as we possibly can to see and feel and think the way they think as a way to help them. Because of course I can walk in their shoes and then I can step out of their shoes and then help them with the process that they go through. And maybe that sounds, I don't know, simple or glib, but it's because what we're trying to do is really understand where people are coming from. And that process of understanding produces a degree of validation and a degree of problem solving. And ultimately, what we hope is that it produces a positive expectancy about the future. And those are the things that we work with. So I have a clinical practice 1 day a week. I have a research program with wonderful PhD students, collaborations with all the cardiology fellows, research studies around the world, and the honor of being here tonight and working with patients all over the world and trying to provide both education and science, not just what might be a good idea, but a good idea that research has shown actually works. Because you can get good ideas from everybody. But what we try to do is evaluate those good ideas, make sure that they are research based, evidence based, so that we provide reliable and valid information. So, if I dodge a question tonight, it's probably because there's not any data on it. So I'm careful about trying to stay within the clinical and research evidence where possible. But it's great to be here, and thanks, Sean, for my introduction and allowing me to share a little bit about what I do.
Yeah, no, absolutely. I remember seeing you on the Heart Warrior project, and it just really jumped out to me as like such an impactful conversation you were having that just felt like we needed to make this happen. I know it's been a little over a year in the making, but we're here today. Now, for the audience, the response to this webinar has been overwhelming. We've received a lot of questions that have come in. So what I've done is I've synthesized those down into what are the high impact thematic questions that we're receiving. So know that many of you influence directly about what we're going to speak about today, although I may not ask in the exact details that you provided the questions. One quick note is there is a poll we're going to send out just to get a sense of who our audience is. So it'll just ask a question. Are you a patient? Are you a medical provider? Are you a family member, etc.? So feel free to respond to that at your convenience, and it should have just popped up on your screen. Cool. Well, with that said, we're going to go ahead and jump into it. We've got a lot of good questions, a lot of tough questions. So, Dr. Sears, you have your work cut out for you today.
Okay, I expected that, so I'm ready.
All right. So let's start with question one. How do people live with the anticipation of something serious that hasn't yet happened, especially if they've seen a loved one with the same genetic variant progress with heart disease? How can someone stay present in life while also preparing with their spouse or family for the future?
Well, that was an easy one. So let's talk a little bit about how we generically think about how patients adjust to what they're going through. When you think about the basic psychologic needs that we all face, we need to understand that we have food, water, shelter, and then beyond that, we need to feel safe. What these conditions do, what heart disease does, particularly to young people less than 50 years of age, what it does is rob you of some of that security, that feeling of safety. So rather than say, how do I cope with uncertainty? I would flip it and say, how do you look for safety and security? What are the things that reassure you? Now that can become an obsession, like you constantly need to be reassured. That's a little bit of a problem. Or it can be on the other side, is like, well, I don't need to be reassured. I don't even have a problem. And so you wind up with this continuum of obsession on one side and denial on the other. And the right answer is probably somewhere in between, where we seek to find security. Well, how do we find security in the context of threat? Well, that's what I call health security. So I compare it to food security. Food security is defined as you have a belief that you have a reliable and desirable food source over the next 2 weeks. Like you're not going to go hungry in the next 2 weeks. Now that's not true all over the world, of course, but food security is defined as I have a reliable and desirable future of food. Okay. Well, health security is similar. Do you have a reliable and desirable health outcome in the future? And those ambiguities, those uncertainties are enough to drive you nuts. But there's some uncertainties about everyone's life, so that alone's not distinguishing. It can be when you know you have a known diagnosis. But my point is this: how do we create security? All right, well, how do we create security? Let's say it. All right, number one, information. To get good information, because when we can understand something, we can identify a threat, it's less anxiety producing. Number two, we certainly can put safety nets in place. Okay, that might be a defibrillator. It might be a medical team. It might be genetic testing. It might be a great medicine. It might be any number of things that are sort of to directly address the problem, to keep you safe from the medical pathophysiology of the condition. Well, what else can we do? Well, the third thing is be a detective for safeties, meaning look for safeties in your life. Remind yourself of the things that do go well. What uncertainty does is rob you of safeties. What it tries to do is say everything that's unknown is dangerous. But in fact, many things that are unknown are not actually dangerous. But in the context of medical threat, and it just feels like one more thing, right? And what we know about psychological health is particularly ruminative or repetitive thoughts are particularly problematic. So we've got to break those ruminative negative thoughts. And while it might seem a little Pollyannish, breaking them with gratitude, breaking them with, well, I worried that something bad was going to happen to me when I drove across town today, but nothing happened. Okay, but see, that's the point. You need to pay equal attention to the signals of safety as the dirty trick that your brain will play on you to pay lots of attention to the negatives. And while that can seem like so silly, but it really is true. This is the dirty tricks that anxiety plays on you, that unknowns are dangerous. No, unknowns are unknown. And becoming a sleuth that's looking for safety and saying, you know what? I worried, but I actually was fine. Everything turned out okay. And doubling down on those experiences because the ruminative part is very easy to come back. It reminds me a little bit of like, I don't know, if you put somebody in a room with dirty, smelly socks and and all they can smell is dirty, smelly socks. Ugh, it's horrible. And they run out of the room and get some air. I go, I don't want to go back in there. But you got to get something done in there. You got to get some work done. Well, if they go in there and they expose themselves to this smelly socks, eventually they won't smell it anymore. They essentially go nose blind. And the point of that is the socks didn't change at all. You changed to accommodate them. And I think ambiguity can be like that a little bit. It can be a smelly sock that you have to kind of get used to. Again, it's not exactly the same, but the point is we can adapt. If we can, if we can unattach some of the fear from unknowns. Unknowns are unknowns. So you can only know what you can know. You can't know an unknown because it's unknown. I'm being silly, but the point is that anxiety has a way of basically saying if there are three outcomes, bad, neutral, and good, anxiety says, well, you probably won't get good. Neutral doesn't matter, it's bad, and bad's bad. So basically, anxiety just convinces you everything's going to go wrong. It's a tough little condition, anxiety. Anyway, that was a little bit of a rant. Uh,
No, as you're
it,
speaking, it reminded me of what one thing my cardiologist told me. He just kind of looked at me one day after he gave me some really tough news, and he said, "Sean, it is what it is." And something in that statement just removed a lot of anxiety for me and it just put me in more of this like stoic mindset of it is what it is. I can control what I can control. I can't control what I can't
yeah.
control.
And for you, that worked. Some people might say, "Well, how dare him say that? He doesn't understand what I'm going through." Okay, that might be true, but for you, it worked. I mean, another example is it's outside. Let's say you go outside and it's raining, and you say, "It's raining." That's the fact. Or you can go out and go, "Oh, I hate that rain. I don't know. We don't need more rain. Rain's terrible. I'm so tired of rain." Blah. Okay, but objectively, it just rained. The rest of the story is generated by our expectations or our judgments or our negative expectancies about the future. It- Objectively, it's just raining. What we bring to the rest is part of the process. Now, the problem is that can sound really incomplete if you say, dude, this isn't rain. This is a genetic condition that puts my family at harm. So it's not so much the case that that's exactly the same. It just means that yes, there is a genetic risk. And here's what we're going to do. Let's go back through this. Let's going to get you some information. We're going to put safety plans in place. We're going to get you medications, devices, treatments, plans, procedures that we need to get you. Then we're going to deal with some of the unknowns and the mental health side. And we're going to focus on how we get through some of these experiences. And we're going to allow emotions. We're going to confront emotions. We're going to say, you know what? It's okay to be scared sometimes. Absolutely. Anxiety is by itself is not something we need to be running from. We need to, in many ways, to embrace the discomfort of it. That sounds terrible. But much of the dread can be short-circuited if we allow some of that to occur. If you just run from it, it doesn't really work. It just comes back around. The good news is that, as long as you're working at this, you're making progress. If you work at stress and anxiety and you say, I'm doing the best I can, I'm being self-compassionate to myself. It's of course I'm scared some days. It's okay. But I'm going to keep on going through it. I'm not going to withdraw. I'm going to keep on hanging in there. And the game is won by playing, by continuing to uh, pursue positive, pursue hope, pursue activities that matter, pursuing your values, pursuing meaning. Um, Again, I know that can be a little philosophic, but it's more than that. It's about turning your attention to the things that you want, not the things that you dread.
That question touched well on kind of the what ifs and the anxiety. Then there's the other side of it, and that's almost becoming like angry or the different stages you may go through in terms of grief and emotions. So, like the example of receiving a diagnosis or an ICD, you can feel restricted, like your old life and passions have been stolen. I recall, one doctor, he was an awful doctor. I stopped, I switched doctors, but he was like, "Hey, how you know your life? Like it's come to an end." And I was just like, it's the wrong response, right? So as you think about people feeling like their life has been stolen, their passions have been stolen, what strategies can help them with moving forward without being consumed by feelings of anger, as an example?
Well, I think first and foremost, whether you're a patient or a family member, or even in this case, your doctor, job one is validation. That is part of why he was so called an awful doctor is that he didn't validate your experience. So this happens all the time. Somebody gets shocked by their defibrillator, and everybody in the ER goes, "You're so lucky. You're so lucky. You got a defibrillator. It saved your life." And everybody in the family is like, "Oh my word, what just happened?" And you see there's a disconnect between the emotions that were being validated and the emotions experienced, and that just creates an isolation feeling. So anger often comes from invalidation, from somebody saying, you shouldn't feel that. You're not allowed to feel that. Why are you upset? This thing saved your life. Why are you upset? And what happens is they don't mean to. Nobody's meaning to do that, but it's invalidating. The experience that you had was that both the arrhythmia and the ICD shook me up. And so you wander into the ER and somebody goes, "You're so lucky." And you go, "You know what? How about jump off the pier. Okay. We don't want jump in the lake, buddy. Okay." And so because that's an invalidating experience. So anger follows often from invalidation or a dismissiveness of the negative experience. And what it does is elevate. Anger has an elevating component, meaning that you didn't understand me this time. So now I'm going to do it meaner. Now I'm going to do it madder. right? It elevates because it's an invalidated response. And so that's why you see things like, the terrible TikToks where somebody loses their mind at the airport or something. Because what happens is the airline does this all day. Look, hey, your flight got canceled. Sorry, you're not going to make it to that wedding. But we put you on Sunday's flight, which doesn't help you any, right? And what happens is that they don't have the capacity to validate, and so people elevate and lose their mind because they've been invalidated. And anger is a way of trying to say, validate what I'm feeling because I'm mad you're not doing it, because it's unfair that this is happening, and you need to validate me. And so we really focus on that. Well, what does that mean? Well, it means that when somebody says to you, I'm really scared, that the most common response is, "Oh, you're okay. You're going to be okay." But the man's answer may be, "Yeah, yeah. Some days are scary, and some days that you've been scared, you got through them anyway." And anxiety is not to be suppressed any more than you should try to suppress your feelings of hunger. That those are natural responses to perceived needs. And you could just imagine somebody, you're not hungry, but you are. And I think emotions have some of that. I mean, I don't think we need to be, chasing our emotions around all day, but I also don't think, because mental health has been stigmatized and people get uncomfortable about negative emotions at times, the response by onlookers might be something like, well, I don't know why you're so upset. I mean, who cares that you missed the wedding? Well, but it was important to that person, and it's invalidating. So I think anger follows from that more often than not. I think it's best managed by trying to get at the root of the concern as opposed to responding to the display of anger. Could you just imagine if you saw one of those TikTok videos, somebody losing their mind about their plane ticket, and somebody said, "I'm so sorry. I know this was important to you. And while we can't fix this, can we work together to find something that might be more satisfactory?" And I think that that's kind of where, in an ideal world, we would try to problem solve with attentiveness to the emotional reaction and attentiveness to the solution to the problem. And I think generally medical care is a solution to the problem and leaves out the emotional reaction to the problem. And so I think that's why we do tonight. We got an incredible. We have 93 people on this call. I mean, I haven't had 93 people that wanted to listen to me in a long time. So why are people on? They're on because the emotionality of heart care is left out. And other than here at East Carolina, where my team is here, there's not a lot of places, almost none, that have some attentiveness to this part of the problem, this part of the experience. And that's invalidating. It's the very thing we just talked about. It's like the airline counter all again, except now the stakes are way higher than whether you made it to some event you were trying to get to. The stakes are way higher because you've been asked to understand and respond to something that is not easy to understand and has a lot of unknowns.
Yeah, and impacts how you viewed your future playing out. It's
Okay. Yeah, you may have to stop me. I'm getting into some rants tonight.
you're good. Now thinking broader than just the individuals,
Mhm.
there's parents in the community that wrestle with how much to share and when with their kids that may have inherited the cause for their cardiac disease. So for parents whose child carry a genetic variant, LMNA is one example of that.
Yes.
How can they balance letting their child live joyfully while also being honest about why they see doctors? And then to piggyback on that, when and how should parents begin opening those conversations, especially given the uncertainty of when symptoms may develop, if ever?
Yeah. Well, this one's complicated because, of course, across the 0 to 18-year range, the relative cognitive development, relative emotional development, moral development changes across that time. So, I need to kind of focus in on that. So, while considering the differences in child development and capacity to understand and capacity to go, let's go to the higher order thing again. It doesn't matter if they're 0 or 18. Am I safe? Mom, dad, caregiver, guardian, am I safe as a 0 to 18-year-old? What have we done to make sure that I'm okay and I'm safe? You guys take me to the doctor all the time. Well, am I okay? Am I safe? So getting at that fundamental psychological safety is still a important principle in at any of these ages. You know, when you're talking about younger kids, then it can be much more concrete, like, yes, you're safe. Whereas with an adolescent, it might be, show me. How do you know I'm safe? How relatively safe am I? But younger kids is going to be a black white difference. Yes or no, I'm safe. As they get older, the gray will enter, right? So, well, I'm not as safe as my neighbor, but I go to these doctor visits, they're monitoring my heart. In some ways, they know more about my heart than the neighbor's heart. I mean, that's kind of true, right? The neighbor might have a problem that's undetected, but you are examined closely. We're doing everything we can to create normalcy so you can become exactly who you want to become. That creating a meaningful life, creating a life that helps you achieve the things that you want to achieve. That might be, to graduate from high school. That might be to go to college. That might be to take a job. It doesn't matter what it is, but knowing that you're not in harm's way because of right information, uh, treatment, the optimal treatments, medications, devices, procedures, attentiveness to the psychologic positives as well, managing and treating the kinds of stresses that come up, that then we get back into the same things we've talked about, like creating safety for your children and indicating that your own faith and security in them and in the processes that we're putting in place. We're at an interesting time, right? I mean, 80 years ago, we didn't know who was in trouble with anything. We just wandered around and bad things happened. I don't know. Don't know what happened there. Today we have that level of precision of information, and in the future we'll have even more. But the benefit should not be lost of that level of precision. That means then that yes, we can identify some degree of risk, and yes, we can put a place in to reduce that risk. And that's exactly what we're doing. So, overprotectiveness is a big challenge for parents to somehow keep them safe in all ways. I like the idea of testing limits. That is, to again embrace some of the uncertainties, embrace some of the edges of the protective units that you want to put in place. Allow kids to do some things that maybe you wouldn't want them to do, but they got to test the limits. They got to embrace the uncertainty. They have to embrace some of the fears. It's the very thing we've talked about throughout this, that unaddressed anxiety magnifies. Addressing anxiety freezes it, if not melts it. So I do think that parents have a great role to play, even though I'm a parent, I understand, gosh, my children, my family's everything to me. And if I thought they were in harm's way, it's very hard to let them live. On the other hand, that's not living if I'm overprotecting them. So I like the idea of find the limits and then push them just a little bit, test them. Are we putting artificial limits on our kids? Are we overprotecting them and then they can't actually feel safe because we got them locked up? They're wrapped in bubble wrap. They can't live life wrapped in bubble wrap. So we have to, I think, give some on the limits and the boundaries and be a little bit flexible about those. That's not easy.
Yeah, no, and speaking of, putting artificial boundaries and stuff like that, I think that that really becomes true when you receive an ICD and you start thinking about what are the chances that I'm going to get shocked? Is this just an anxiety attack or am I having an arrhythmia?
Mhm.
So to your point, I think information helps put a lot of that at rest mentally when you start to understand um, how common a shock is.
Yeah.
Like,
Well, let's talk about that for a minute.
yeah,
I
okay.
ask our patients, hey, what do you think the chances of you being shocked are? And they go, 50-50. And I say, no, it isn't. It's nowhere near that. It's 4 to 6% over the course of 365 days. That means around 95%, to split the numbers, 95% of IC patients, that device will be silent this whole year. Now, the trick for us, though, is for the 5% that are shocked, we need to make sure that all of our patients know what to do if shocked. Therefore, one shock, feel fine, let us know. Two shocks, don't care, come in. One shock, don't feel good, come in. And remote monitor, use the device to send rhythms, right? But so we have to prepare all 100 patients for a 4 to 6% chance. And unfortunately, sometimes when we do that, we stir up another, frankly, about another 15% gets stirred up by our preparatory process. Um, the rates of anxiety for our ICD patients about 22%. So, that's how I get that number, right? At 4 to 6% are shocked and about 15%, about 22% are anxious. So then there's some people in there who haven't been shocked, at least if you use annual rates only, that number accounts for people who are worrying about it, right? We really try to teach our patients that there's very little your life should not be limited by the device. There's very few things that we even need to worry about with the defibrillator. I've been accused of being a cavalier about that sometimes because I do think that giving somebody a safety net like a defibrillator and then saying, "Oh my gosh, what if the safety net's activated?" is like, well, I don't. That's why we have a safety net so that you can live. The safety net shouldn't be the reason you don't live. Usually it's the condition that's going to limit you more, right? So it's actually the cardiac function that's going to limit more than the device. But I don't want to be cavalier about that. I mean, I do know that, as I said in the intro, what we've done is get much more focused on specific fears that go with defibrillators, specific fears that go with aortic uh, aneurysms, specific fears that go with chest pain, specific fears, atrial fibrillation, palpitations. What are the specific fears? Not, are they generically anxiety? I think at least my lab and my work we're past that now. We're not worried about diagnosing anxiety disorders. We're worried about the experience of all 100% of patients. So that what we do is walk in every single patient's shoes, predict, forecast, recognize the threats that they feel that are common across all patients, not just the ones that have anxiety disorders of some sort. Anyway, um, so I do think that the defibrillator is an interesting thing. We can talk about that some more, but I could go on forever. That's been the focus of. If I had to say one thing I've worked on my whole life as a professional, and probably written, well, I know we've written more papers than anybody in the world on how to manage a shock experience and how to manage defibrillators because I'm convinced it's a fantastic technology. It's just that we haven't really engineered the human as good as we've engineered the device.
That seems right. Now, for those that have gone through a traumatic event like a cardiac arrest or an ICD shock, something along those lines, PTSD and ongoing distress can be real challenges. So I'd be curious, what evidence-based treatments or approaches have you found most effective in helping patients recover mentally?
Yeah, so PTSD is well studied in other areas of health. It's quite well studied in ICDs as well. And a couple of things. First and foremost, the treatment for PTSD is exposure to what you would like to avoid. So it is approaching the very things you're afraid of. So that might be returning to exertion. That might be returning to the place a shock happened. That might be um, thinking through what happened and talking exactly about what did you think then? So it was a Tuesday, and I knew that my stomach didn't feel good, and I was just having a bad day, and I just kept thinking, what if something bad happens to me? And then it happened, and helping people to actually work through the details, the narrative, the literally the individual experience that went with the traumatic event, and helping them in the long term master it to essentially be able to tell their story without it creating the same arousal. So what is PTSD then? PTSD is hyperarousability, strong desires to avoid the content of whatever the trauma was, and and then a ruminative process that involves things like nightmares or um, intrusive thoughts, invasive thoughts, as I like to call them, like an invasive thought. Like I don't want that thought, but it keeps coming in. It's sort of the same way as like, um, if I said, "Don't think of a purple elephant right now," and most everybody's like, "Whoa!" But just popped in my head. Well, the triggers for these kinds of traumas can come about that way. I mean, it could be as simple as hearing an ambulance, which is a common experience for all of us. Yet if you've had that traumatic experience of someone you love being picked up, that ambulance siren sounds totally different the next times you hear it. And so I think PTSD is a very powerful mental process that follows from traumatic events. And again, rather than say, I don't want any of that PTSD, it's like, okay, but let's talk a little bit about what happened here. Why what the anxiety follows from a potentially life-threatening event that you witnessed or were involved in. The brain does want to remember that because that's been an evolutionary value set for hundreds of years. I mean, you can't, caveman Bobby couldn't go into a cave with tigers, get his arm ripped off, and then go, well, I'm gonna just go in this next cave. There's probably something good in there. No, caveman Bobby needs to remember that things he can't see in the cave might have something dangerous in there. And now it may also be that there is something good in the next cave and so he doesn't go in. But that's the nature of PTSD. It's this relationship between approach and avoidance and a self-protective response. So what do we do? Let's talk about how we treat PTSD. Number one is exposure. So we want people to tell us about what they've been through and get used to talking about this and actually speak the fear. Number two, what we do is certainly teach them about how PTSD is working. And I just did that by talking about, PTSD is not the enemy, it's a response. Third thing we do is help them re-engage in life of what they fear. The next thing we do is certainly support them in emotional ventilation so they can talk about the feelings that are the fears and the scary things, the traumas and the the futuristic fears that they come up with. We certainly work with them on how they perceive situations. We get them used to triggers. We do things like get them back into action so their behavior changes, their thoughts change, their emotions change. And we approach these things. But you got to hear, like, this is not some casual, "Oh, I'll just read a book." That's not how this works. I mean, I wish it did. Um, PTSD is a very challenging condition in which um, basically doctor, patient, and family have got to work together to reestablish a sense of safety and security.
When it comes to types of therapy, right? So you spoke to one, I guess, a concept I was familiar with, which is some eye movement therapy, which really the focus was like kind of relive the experience, but keep your eyes busy and start to train your brain. Then there's other types of therapy like hypnosis, etc. Is there any particular type of therapy that you find to be most impactful?
Well, it's not what I find or what I think, it's what the data says. The data says cognitive behavioral therapy for PTSD with ICD patients has been established. And we showed that in multiple large scale studies now that this is actually quite helpful cognitive behavioral therapy can dramatically reduce anxiety. We've shown also that cognitive behavioral therapy changes what's called salivary cortisol, which is an enzyme in your spit. So we actually had studied that years ago. We drove around Florida and picked up people's spit. It's a specific laboratory protocol, but we actually can take spit and spin it and actually look at what essentially is the inflammatory adrenaline response of stress in cortisol. And So we've shown it that that cognitive behavioral therapy addresses physiology, it addresses psychology, so anxiety is better, shock anxiety is better. We did this in a large clinical trial up in Canada. There have been multiple other investigators since. We can feel very confident that cognitive behavioral therapy does, in fact, address anxiety quite well. And there was a recent meta-analysis by Mitch McManus in Australia that put together all of these studies and again showed while the studies could be better, we could have higher quality studies. There was sufficient evidence to conclude that cognitive behavioral therapy for anxiety in ICD patients was effective. Um,
Could you clarify what cognitive behavioral therapy is for those who may not know?
yeah, cognitive behavioral therapy is just kind of the modern therapy. Cognitive refers to how your beliefs and your um, thoughts are contributory to the problem, and then how your behavior is contributory. So it's a changing of thoughts and a changing of behavior. That's why it's called cognitive behavioral therapy. So changing thoughts and changing behaviors. So what that would look like would be well, I got shocked when I was running down the street. Well, okay, so what do you think when I run down the street? Well, I don't want to do that. The last thing I want to do is go running down that street ever again. Well, that's a thought. Well, so you don't run down the street, and you don't do the behavior, and you have these thoughts. And so therapy targets both the thinking pattern and the behavior that lead to that level of avoidance. So we're constantly, like for example, patient says to me, well, I got a 50-50 chance of being shocked. That's a thought. That's a cognition. But the truth is that's wrong. I mean, that's just flat wrong. And so that's not his chances of being shocked. And so we might say, well, if I thought I had a 50-50 chance of something bad happening to me when I drive home from the office, I'd probably stay there all night, right? I mean, that doesn't sound like very good odds. But there's not zero risk either, right? Driving home from the office is not a zero risk. And so cognitive behavioral therapy would help understand some of the beliefs that lead to both avoidance behavior and arousal. I mean, if you really believe that you're in harm's way right now, then your body will respond with anxiety because you are in harm's way. That is, you think you're in harm's way. The body doesn't try to separate that very much. If you convince it, it's well, better get some adrenaline going. I better get my heart rate going. Better get my breathing going. I need to change the way the blood's moving around so I'm ready to fight or flight, right, or freeze, and that happens. So anyway, so cognitive behavioral therapy just gets at the thoughts and actions that go along with adjustment.
Now, looking at it from the angle of spouse or partner, I imagine this one's got to be a little challenging because what are they thinking? What are they experiencing? What's their view of their spouse and their partner? There's I think a lot that may get conflated in there. Um, so I guess where I'm going with the question is, what recommendations, resources, etc., should a spouse or partner be considering, both for their own mental care as they're watching a loved one go through this, but two, to help them support the patient in a very vulnerable moment and potentially lifelong thing they're dealing with?
Well, I'm smiling at you because we have a paper that we wrote for patients and spouses called Coping with My Partner's ICD and Heart Disease. And then we go over 16 strategies for spouses. It's free online. You can get it. It was written in 2009, if you can believe that. But it's still as true as it ever was today. I mean, the key ideas involve getting good information, getting good conversation, good information, good conversation, good confirmation about how can I help. Uh, certainly managing your own fears, making sure that you have that the as a spouse, you're managing your own anxieties. I think certainly building a team that the couple, and if we're talking about a couple, in the case of a couple, being able to share the experience, share the load, share the excesses, share the safeties. Like I feel safe because you have that defibrillator. I feel like I can reach you if I need you. I think we've got the best team in place. I want us to get back to engaging in life. I don't want us to avoid anymore. Ways in which we can sort of draw somebody who's anxious and wants to withdraw and actually engage them. The more that spouses can engage, they can really make a difference. And certainly getting back to normal. One of the things we ask patients is, is there anything you're avoiding? And people say, yeah, man, I'm avoiding exertion. I avoid sex. I avoid feeling angry. And you say, but those are parts of life. Those are hard to avoid. And so that's something a partner could help with, right? I mean, one obvious way they can help, but being being comfortable with returning, testing the limits, as I said earlier, even as a patient and a spouse, testing the limits and recognize I'm going to be okay. I have a plan here. My medical team has said we can do this stuff. We can get back to living life. We need to. We can do it slowly. We can do it stepwise. We can take our time in each of these behaviors, but we will win. We will win. That if we work as a team, then we will get back to normal. We will pursue that, pursue, pursue, pursue. Limited only by, true medical limitation. If you get short of breath from minimal activity, okay, then we got to find a way to get you doing as much as you can do with that limitation. Um, so anyway, so there we have a paper out there on that. There are lots of things, but I do think being teammates on this is essential.
I'd be curious, and maybe there's not like a definitive answer or a good one to this, but how frequently would you say it's the patient that more needs the partner's support to navigate something versus the partner needing the patient to kind of lead them through this will be okay?
Well, here's the dirty secret. Spouses and patients have almost identical, in the largest data set we have, 22% of patients, 22% of spouses have an anxiety disorder. But remember, that's just the ones that have an anxiety disorder. I've been talking about 100% all night. So all families, all couples need some level of support in returning. And our best data sets, it's equivalent. In my experience, it is often a spouse that's really struggling in the background. And often because they're invalidated. They come to a clinic visit with the cardiologist and the spouse is there, but they may not even talk to the spouse. But the spouse is sitting there brewing over all these concerns. The family member says, well, how you been doing? Been doing great. Meanwhile, the spouse is like, what? Pulling their hair out. So it's a dance, right? It's a dance of uncertainty, of return to normalcy. And the dance means two people are in it. There's no, it's not what I don't know what you call that when you dance by yourself. I guess, if you were like one of those guys that used to spin around on their back and
Break dancer?
break dancing. They're not
Yeah,
break dancers, right? I mean, the
yeah.
truth is you're Arthur Murray, right? You're in a traditional dance in going through this experience in life. And I do think, and I'll tell you right now, one of the reasons I love to come to work is I believe this, and I believe this fully. I believe that people can experience heart problems and come out psychologically stronger than they went in. And the reason people go, "Oh, come on, man. Come on." But it is the case that the experiences of our life, as harrowing and threatening as they might be, do produce a reprioritization of the things that we love and value. There's good evidence for that. You can look at breast cancer, you can look at heart attack patients. When you look at the long-term and long-term adjustment from these things, and I'm talking, 8 years, 10 years, heart patients will say, well, I made a lot of healthy changes. That's the most common thing they do. They eat rabbit food now, and they used to eat, I don't know, candy bars. But the second thing is that they say is that I have a greater priorities in life. And they have it more than actually cancer patients even will say that there's something about cardiac disease that shakes people's priorities. And they really do, I think, there's an opportunity, I'll put it that way. There's an opportunity for a reprioritization. There's an opportunity for a distilling down of the most important stuff in life and a little bit less of the nonsense. And I have to tell you, Sean, that my life's work, being in the presence of heart patients for all these years, I have taken that message to heart that I'm a better person in every way from being around the courage that my patients have shown me over the years. They've taught me. You couldn't help but you can't help but learn from them. It's not always perfect. It's not always glorious. It's sometimes really, really hard and really, really sad. But they do find a way through it. And in many times they become stronger from it. And I really wholeheartedly believe that that's capable, that every single person is capable of that, including spouses, including families. These experiences in many ways can temper you in such a way that you become stronger.
Yeah, I would personally agree. I think the whole, in my case, the situation was unfortunate, but I feel like it's made me a better person. And it's interesting. I came into this webinar, like I speak in front of like very large organizations regularly, and it never stresses me out. I've had some coworkers go like, Sean, you just don't seem to get rattled. I'm like, 'cause there's bigger problems in life than like professionally what I'm about to talk about. I actually got nervous for this one because it's a topic it is that elevated importance. So again, long-winded way of saying I agree with you. I've personally experienced it, and I imagine there's many people here that have felt that kind of level up or that reordering of importance in their life.
Well, for the record, I was nervous about tonight simply because I want this component of heart patient care to get the attention and value that it deserves. I want to be useful. I want to help people see a way through this. I want to communicate clearly about this is not this is something that can be managed. It's not easy, it's not glorious, but it can be managed. And if you're struggling in some way, you got to get some help. I mean, let's get over this mental health stigma. Let's make mental health cool. I mean, seriously, it's like, who doesn't want to be mentally stronger? I mean, I want to be mentally stronger. And I think people that logged on tonight wanted to become mentally stronger. I don't think that I don't think it's a very easy thing to talk about, but I mean, we certainly tried to get at some of those comments like about this idea of both normalizing some of the challenges, strategizing about some of the challenges, and then looking forward to some of the positive future developments and seeing there is a way through this.
Now, you touched on the thing I wanted to raise as my last question. A common theme I generally see across the cardiac patient community, if you will, is my doctors need to understand this topic more, and it could be my disease, it could be an aspect of it, like the mental aspect, etc. So, if there was something that the people watching this right now that could take away, and they could go to their care team with and say, "Hey, look, we've learned from Dr. Sears, and we feel there's value in your other patients might get from hearing him speak." What is that takeaway action we can do to help make the mental part of this a cool topic to talk about?
Well, that's a tough one.
You'll find that patients really want to educate their team in areas they feel that they could be better.
Well, the way that I think about this is that this is just simply a comprehensive view of the situation. To have a person come into your office with some broken part. I'm going to keep it really generic. Some broken part. There's a tendency for medicine to see that as, well, I just need to fix that part and then the machine will work great again. But the problem with this is that our bodies are not machines and they're connected to a thinking, feeling being. Thank God, right? That's what makes us most human. And so the first thing I would say as a takeaway is that the mental side of this is expected and normal, right? I mentioned my evolution as a researcher is to really say, well, it's 100%. The psychological side of this is 100%. Every person has a psychological. I'm no longer going to go find the people that need a diagnosis that the insurance company needs to be able to bill. I'm going to say every patient has a psychological component because if it affects the heart, it affects the mind. And I think part of it then is if the message I would say to the team is first that, of course, there's a psychological side. How could there not be? Number two, help me get back on track with my actions. So number one is acknowledge the emotion, and number two is get back on track with actions. Now, the best way to do that in a perfect world would be cardiac rehab. Why? Because cardiac rehab is a way to expose yourself to the fears of exertion, engage in activity again, and actually be a little bit frightened in a safe environment. And I think the third thing is to cultivate both a validation of about emotions and a valuing of emotions. Like, yeah, of course, it's okay. Yeah, how can I help? Yeah. So this was frightening. Okay, so what we need to do is simply say, was that fear proper? If somebody said, "Well, I'm going to get you, and I'm going to get you when you don't know it," well, that you should be anxious. But the thing about our hearts is that we then say, "Well, someone's going to get me every day." Well, we have a plan in place for that. We're going to make sure that we have a plan in place. So I think educating the medical staffs about, of course, there's a psychological component. I need help getting on the behavioral action side, getting back to doing stuff, get back in the swing of things. And then finally, to follow up and make sure that we're continuing to make progress so that if you did get stuck somewhere along the way, you activate the family, you activate the spouse, you activate a lot of people who could help. I mean, all the way from clergy to friends to dogs. I don't know. I mean, lots of things can help us get back to normal and give us support when we feel down and we feel like maybe we can't get through it. But in fact, we can. And what works best is by confronting and embracing uncertainties and fears rather than trying to say, well, I'm fine, I'm fine. That's just going to bring it back around. We're human. We're allowed to feel. We're allowed to be frightened. Um, it doesn't make us weak. It makes us human. And I have great admiration for the courage to talk about emotions. I say this all the time in clinic. I say, "Yeah, I just can't. I'm just really impressed. You came in here and laid it on the line and told us exactly what you thought and felt." I mean, I think that's great. That's not easy for me to do. So I admire that in our patients who are really trying to complete the story. And I think that's my final point is that my experience with this disease, doctor, is that yes, you took care of the technical side, but there's still this rest of the story, this emotional, then in which to, if you want to see the whole story, you have to include this component. Um, so that's what I would say. Now, the final point is that we are trying to build a network around the United States of people who, mental health professionals who could be more attached and engaged to cardiac clinics. Presently, there's just not a very good network at all. So we are working with some of the different associations to try to um, identify a network, train a network of people who could respond with greater precision and technical expertise around the mental health side of specific cardiac diseases.
That's great. I think as that comes together and you put together a one sheet or a flyer or something like that, you should share it. Again,
Hmm.
cardiac patients have a lot of opinions. They love to share information, so we can help you help us, more or
No
less.
question about it. We welcome that.
Hey, well, we are at the top of the hour. So I want to thank you very much for your time, Dr. Sears. We actually had more questions than I was able to ask, and some questions that came in over the Q&A. So we might look at doing another session in the future. But for everybody that's here, just know this is recorded. We will get it published. And again, just thank you so much for your time, Dr. Sears.
What a privilege to be here. This is the work we do every day. I want to get it to as many people as we can, and thanks for giving me the chance to communicate it so widely. And thanks for all these folks showing up tonight.